Good morning. A beautiful winter morning this morning. It reminds me of my early days back in Ohio, where it would tend to start to snow around this time. Thankfully, we don't have to deal with that here. I want to welcome everybody to the 6th Annual Faces of PAD. We sincerely appreciate your presence here today. It's a remarkable event that we've started off as a very modest educational gathering, and it's really bloomed into a great event for our people in the region that take care of many patients. We extend our heartfelt gratitude to those actively engaged in this event and all of you who have registered and joined with us. Together, we are here to explore and deliberate on the various treatment options and methodologies, seek to enhance the effectiveness of patient care, and through these endeavors, aim to achieve and improved outcomes and results for our patients. Your participation and commitment at this ongoing dialogue is integral to our shared mission, and we look forward to a day of productive discussion and meaningful insights. And thank you for being a part of the journey. I want to thank, first of all of our speakers who have brought their time and talent and expertise to the conference today and given their time to share the passion for education for our providers for the region. I'm not going to list everybody, but you'll hear very soon get to meet all of them. Again, thanks to our audiovisual teams, Encore Events, and Six Strong Media for putting on this great show for us. It's always been great working with you guys. And the amazing team at Embassy Suites. Lastly, I have to do this now before I forget. I forgot one year and I couldn't live it down. But I want to thank Tracy Lassar for her organizational force in actually putting all of this together. She has worked hard to get through the TMA CME hours for everybody here. There are 8 hours available that you can claim. Rules on that, just very quickly, you have 1 month to claim your credit. After that point, you lose your ability to claim the credit. So as you leave, make sure that you gain the papers that you need to get the credit that you deserve. We need to thank our sponsors for this event. This is a free event, free CME for our community. And as you know, in life, nothing is free. And so the sponsors are the ones who actually make this event possible. So if you can, please take a few moments and look at the booths and talk to them about their devices, their wares, and this is their chance to reach out to the medical community and explain what they actually do. One other noteworthy item on the agenda: at noon today, Dr. Will Harris at VIC will be giving a live case presentation. So that is during our lunch hour, and you can move around the room and get your lunch, but there will be a live case that will be proctored by myself and other physicians around the country. There'll be numerous doctors around the country that will be involved with in the case with discussions, so you get to hear what they talk about. There's a 2D version where people can interact, but there's also 3D headsets where physicians can actually be in the room and actually learn what's actually happening. We encourage you to visit the Terumo booth. They're the ones that are sponsoring that event. One thing I guess I'd like to say is that, and this is really to the participants of this course, I've been involved with education for over 20 years. I've taught medical students how to be doctors. I've taught surgical residents how to be surgeons, and vascular fellows how to be vascular surgeons. And that's been one of the highlights of my career to do that. So I've always been enjoyed education as part of this. And I just always tell my students that one thing that's important is that you're in charge of your own education. So if there is a question you have, seek it out. figure it out. We're here to help. You have experts here to answer the questions. We have a specific style that we have set up today, so there'll be speakers speaking about 10 minutes in each, with 4 speakers per session, and then we're going to sit at in the chairs here as a medical lounge, like we used to do many years ago, and talk about cases and maybe answer questions that might be relevant. Because I think a lot of people, if there's a question you have, someone else is thinking about it too. And then lastly, the theme for this conference is our vascular health can determine the length and quality of our lives. Our vascular health can determine the length and quality of our lives. And we are as old as our arteries. And that's a very famous saying. So with that, I'm going to start off by having Dr. Alison Bailey come first. I believe she is first on the list. And I'm going to ask the speakers to introduce themselves and tell just a little bit about who you are and what you do. I would like the speakers to, when they finish their speech, to have a seat, but then when we've concluded the 4 sessions, or the 4 speakers, to come back up to the podium, and then at the end of that session, if you are no longer speaking, you are free to go and going back to taking care of patients. So without further ado, Alison Bailey.
All right, great. It's always great to be here. This is one of my favorite conferences of the year. I remember when I first moved to Chattanooga in 2015, Chris Lassar sent me a message on LinkedIn and said, hey, we need to work on prevention in Chattanooga. And he was doing a conference. It wasn't this big yet, but that was my very first introduction to Chattanooga. And so I'm a Kentucky native. I'm a cardiologist, and I specialize in heart failure and prevention, which seems like 2 very different ends of the spectrum, but they're really a continuum. So I tell my patients in my prevention clinic, I don't want you to be in the heart failure side. In the heart failure side, we focus a lot on prevention. I'm not going to talk about heart failure today. I'm going to talk about physical well-being and how do we make ourselves feel better. But if I can help any of you in the future, you reach out and let me know. We take care of a lot of patients. I work with a great team, much like Dr. Lassar does, with physicians and nurse practitioners. And so together we make a great team. And, I really do believe in team-based care, and I think that's the future. And so I like to start my talk, any talk I give, to say that prevention is really the most important thing we can focus on, not only in our patients' lives, but in our lives as well. And I like this diagram. It's actually from the AFib guidelines, but it talks about how the patient's in the center, and there's a whole team that supports that patient around the edges. And that includes physician, nurse practitioners, exercise therapists, psychosocial health, all of the things that we need to do to make ourselves healthier. And so, again, the best way to prevent disease, the best way to minimize disease is to prevent disease. And all the things I take care of every day, atherosclerotic disease, heart failure, peripheral arterial disease, and AFib are very preventable disorders. So healthy lifestyle. So I thought I'd just start out by talking about the prevalence of peripheral arterial disease. If we look at men, what we see is that it goes up as we get older, but if we look at the ethnic and racial discrepancies, we see that African Americans are impacted way more than other populations. In the blue graph, the light blue is African Americans, males, the dark blue is whites, and then yellow is Hispanics, orange is Asian, and red is American Indians. So that's in males, and when we look at females, we see a similar discrepancy. So that's one of the things that we have to recognize, is there are some race and gender differences. And this is another graph that just looked at the same thing over our lifespan. And African American, both males and females, have a higher prevalence of peripheral arterial disease. And one of the things that we have tried to come up with is, why is this? Is it genetic differences, or is it other things? Well, one of the things I think is really important to think about are the social determinants of health. We all know those things, but we don't necessarily think of them as something that's modifiable and treatable. But I'm going to encourage all of us to think about that. So we know that cardiovascular risk factors in general go up with decreases in socioeconomic status. So as our income level goes up, our likelihood of having atherosclerotic cardiovascular disease goes down, as does our likelihood of having cancer, COPD, and a lot of these other disorders that we see over chronic health problems. However, smoking prevalence is higher with lower socioeconomic status, so is obesity, and so is hypertension. So we have to think about this. And if we look at our life expectancy at birth, The states in red have the lowest life expectancy. And if you look at the state in bright red, Mississippi, and compare it to some of the states in the lightest blue, there can be a 15-year difference, 15 to 20-year difference in how long you live when you're born based on your zip code. So we're learning that your zip code is as predictive as your genetic code for many people at how long you'll live. And again, this is another way to look at it. Life expectancy at birth in the United States, red's bad, blue's better. And why is this? Look, it's geographic. Part of it's probably lifestyle. Part of it may be genetics, but a lot of it is our environment, how we live. And that's really what the social determinants of health are. So if you look in Chicago, in a 5-mile radius here between the north side of the city and the south side of the city, there's a 16-year difference in life expectancy in people born in those areas. You see the same thing in Philadelphia. 5 miles gets you 20-year difference in life expectancy. And Atlanta, which is very close to us, 10 miles will get you 13 years difference. And then in Kentucky, where I grew up, if you look at the suburban versus the rural counties, about a 8 to 10 year difference in life expectancy. And so those are not just genetic traits, those are social traits. And so things that are happening in our communities. And so the social determinants of health really are those things in the environments where people are born, live, learn, work, play, pray, and age. So it's everything about our communities that make us healthy, besides our genetics. They affect a wide range of health functioning and quality of life outcomes and risk. And if we look at what they are, it's education, access, and quality. How good are your schools and can everyone access them? It's healthcare access and quality. Do you have access to quality healthcare? It's people like us who are taking care of patients and trying to explain how to prevent disease. It's your neighborhood and your built environment. Do you have access to fresh food, to healthy food? Do you live in a food desert so you can't get that food? It's our social and community context. Do we surround ourselves by people who are supportive and help us, or do we not have any social help? That's a huge determinant of how long we live. And then our economic stability. Can we get a job? Can we keep that job? All of the things that we take for granted every day, we have to think about. And this is just a different way to look at it with all the different points. But if we put all that together, we come up with these social vulnerability indexes, and they vary across the United States, and you can look at them on state level or county level, and there's lots of things online where you can go to and look at this. They're associated with cardiovascular disease, risk factors, and mortality, and that is independent of age, gender, race, ethnicity, employment, income, and healthcare coverage. So those are the things that really affect us every single day that we live. And if we take these social vulnerability indexes and we look at premature cardiovascular disease death rates, they look exactly the same. So what we see is that these social determinants of health explain a lot of the discrepancies across this country in access, in how people do from a overall health standpoint. And what we see is that rural counties, so we already knew middle-aged adults had increased risk, men have increased risk compared to women, and non-Hispanic blacks have increased risk compared to other race and ethnic groups. But rural counties also have increased risk, and we're seeing this divide between urban, suburban, and rural increase as hospitals close down in rural areas and access to health care becomes more limited. So think about that in this area we live in. There's 2 papers. One was in JACC, which is the American College of Cardiology journal, assessing and addressing social determinants of health. And then there was one in Circulation. If you're interested in this, these are both great papers to learn a little bit more. But why I find it really important is if we look at these differences, we know that our black neighbors have a much higher mortality than other races and ethnicities. And if we start looking for adjustments, this is how we do things in scientific assessments, if we look at social determinant, if we look at not only age and sex, because we know men have a slightly higher risk than women, and then we adjust for metabolic risk factors, things like diabetes and hypertension and hyperlipidemia. And then we look for behavioral risk factors, things like smoking and alcohol use. But if we add in those social risk factors, we can see that we start to close that divide. And that's really what we want to be able to do. We want to be able to say, why do people have worse outcomes and what can we do to improve those outcomes? And I think when we're thinking about vascular disease, this becomes even more important. And so primary prevention of cardiovascular disease, which is both heart and vascular system, we have to look at traditional risk factors, things like high blood pressure, lipids, but we also have to look at other risk factors. Adverse disorders of pregnancy, for instance, are now a known cardiovascular risk factor. If you had gestational diabetes, hypertension, preeclampsia, eclampsia, early delivery or low birth weight, that's an increased risk for cardiovascular disease over your lifetime. And then social determinants of health are something we should always think about. Not that we can change all of them, but we need to know our own communities and see where we can provide help for individuals who are struggling. And then psychosocial risk factors, that becomes important, things like anxiety, stress, and depression. And so Life's Essential 8, which is something by the American Heart Association, is one of the things I think about every day. We know if we have all optimal health factors and health behaviors, our lifetime risk of cardiovascular disease, if we've got this at age 50, is less than 1% in men and women. And compare that to men who have 2 or more, it's 70%. Women who have 2 or more, it's 50%. So if you get a total cholesterol less than 200, a blood pressure less than 120/80, a fasting glucose less than 100, and a body mass index less than 25, optimal diet, adequate physical activity, no tobacco use, and healthy sleep, then you're doing pretty much everything that you can do to make yourself the least likely to get disease in your lifetime. When we talk about physical activity, optimal is more than 150 minutes a week of moderate activity, something like walking, so that about 30 minutes a day of walking. Or if you do more vigorous activity, things like tennis or pickleball or running, it's more than 75 minutes a week. But if we look in the United States, most of us don't get that. Most Americans are sedentary about 8 hours a day, and then they get light activity about 8 hours a day, things like walking around at work. And exercise is medicine. It does all sorts of things. So anytime that you're exercising, you're preventing disease. This is all the different things it does, but it improves lipids, it improves blood pressure, it improves weight, it improves all your metabolic factors. And if we look at people, both men and women, who have the highest fitness levels, the yellow's the highest fitness levels, whether you have cardiovascular disease or no cardiovascular disease, those who can get above 10 METs on an exercise stress test, which is the equivalent of walking at a moderate pace 30 minutes most days of the week, have a mortality that's about half those that can't get to that level. And I love this graph. This is one of my favorite graphs in all cardiovascular medicine, but it looks on the left-hand side at the high risk, high cardiovascular risk, and that's people who get no activity. And if you can change that none to just a little bit, walking 5 minutes a day, your mortality risk goes down substantially. Now, the more activity you do, the more the curve comes down, but then we start getting on the flat part of the curve where we don't get as much return for our investment. So some activity is better than no activity, and I tell myself that every single day when I'm tired. So trying to get some activity in. Most U.S. adults do not meet physical activity guidelines. If you look at males and females, less than 25% of people meet the recommendations, which are the minimum recommendations. And then if we're talking about claudication or leg pain, exercise is a great treatment. And we know there's lots of things that go into claudication, and obstruction to flow is one of them, and so that's where Dr. Lassar and his team can put stents and do surgeries. But exercise also helps drastically because it changes the way our bodies work. And when we study that, exercise versus stenting, we see that exercise and stenting both improve peak walking times. And if we look at the change in sort of lots of different measures, pain severity, walking distance, walking speed, and stair climbing, exercise gives us benefits. It's not quite as good as stenting in most groups. You get more benefits with stenting, but the two go together. So anybody that's got peripheral vascular disease should be prescribed a walking program. And walking really has shown the most benefit in those with peripheral arterial disease with lower extremity symptoms. And so this was a big meta-analysis looking at exercise training, and for this study it was all walking. And what you can see is people got the most benefit who did the most exercise. And this looks at all different things, but basically if you got more than 30 minutes, if you did more than 3 sessions a week, if you did more than 26 weeks, you walked to the point of maximal pain, and you walked versus other activities like different modalities like biking, walking. Walking was the most beneficial. So walking, longer sessions over time. And the guidelines for peripheral arterial disease would say everyone should attend a rehab program that focuses on walking. If we talk about a healthy diet, most of the U.S. doesn't get a healthy diet, and really it's a diet that's fresh, high in fresh foods and low in processed foods. Nutritional security is the other thing we're thinking a lot about, but do you have access to healthy foods and can you afford them? This is a map of the United States, and the dark green is bad. If If you look here in Tennessee, about 12% of our population has food insecurity, and 61% of our population is above the SNAP threshold for poverty. So 38% of the patients we see qualify for SNAP, or what used to be called the food stamp program. So we have a lot of people living in food deserts that don't have access to healthy food. I'm a big believer in whole food plant-based nutrition, which means not refined foods. Majority of foods are plants, grains, legumes, and no processed meat. We should stay away from ultra-processed food, which is food that we can't tell how it started in life. And a study of over 40,000 adults showed that a 10% increase in the proportion of ultra-processed foods was associated with a 14% higher risk of all-cause mortality, death rates. Red meat's also associated with increased mortality. I'll tell you, 7% of the deaths in women could be prevented at the end of follow-up if all the individuals consume less than a half a serving a day. Doesn't mean zero, but minimizing our red meat. And then plant proteins can improve quality of life, even in dialysis patients. We talk a lot about sodium, and if you look in the United States, the red is sodium. And the red is from food that's already added. So processed food is where the sodium in our diet comes from, 70 to 90%. And sodium makes our blood pressure go up. And then the last thing I'm going to mention is just what is normal cholesterol. If you look at hunter-gatherers that live in the wild, people have a total cholesterol of less than 150, a total cholesterol of less than 150. And when we're born, it's about 30 to 50. And if you look at this populations, the LDL is about 50 to 75. If you look at the adult American, our total average is around 190. And so we know that the lower your LDL level, no matter how you get it there, the lower your risk of vascular events. And this is a graph that looks at lots of different ways: lifestyle, statins, PCSK9 inhibitors, surgeries. And we're now talking about these LDL years. So the higher your LDL over your lifespan, the more likely you are to develop cardiovascular disease. So a healthy lifestyle improves lipid levels. Things that you can do in your diet: a DASH diet versus a standard diet will lower LDL about 10 points. Vegetarian versus an omnivore, about 12 points. And then lowering simple and refined carbs will lower your triglycerides. If we look at our guidelines, our high-risk patients with ASCVD, which includes anybody with symptomatic PAD, should be aggressively managed, and high-intensity statins are recommended with an LDL goal more than 50% reduction to less than 55. That's our new guidelines, and that's now in line with the European guidelines, which says the same thing. However, we do a very poor job in the United States and around the world. If you look at these patients who didn't get to the goal, and the goal was 70 at this time, only 17% had lipid-lowering therapy intensified over the next 3 years. So if we're not getting to guidelines, we need to. And then I'm going to finish very quickly with talking about the blue zones. The blue zones are one of my favorite things, and there's a Netflix series on that's on right now. There's 4 different episodes, but it looks at places where people live the longest in the world free of disease. And these were the initial blue zones, and Loma Linda was the only one in the U.S. Who knows what Loma Linda has a lot of? Yes, Seventh-day Adventists. And so Dan Buettner was a social ecologist with National Geographic, and they got together and they looked at where do people live to age 100 free of disease. And they created these maps, and where they were, the highest density was the blue zones. So in the blue zones, there's a common set of themes. People downshift. Everybody has stress in our lives. They find ways to deal with the stress. And there are different ways. In that documentary, they go to each of the blue zones and they talk about these. There's a plant slant. Most people eat lots of plant-based foods, not necessarily because they said I'm going to be a vegetarian, because that's what was available and financially viable. But beans are a staple environment in all the blue zones. And meat's eaten on average about 5 times a month, small servings, and it's mostly pork. This is one of my mentors. He's a cardiologist. He was the president of the ACC, and he said there's 2 kinds of cardiologists: vegans and those who haven't read the data. So I like to put this slide in when I'm talking about food. And then in all these communities, there were similar lifestyle traits, and they tend to be the same. And people move naturally. They have a purpose, something they believe in, something that makes them get up every day. They downshift or find things they enjoy to de-stress. The 80% rule, which means when your belly's 80% full, you should stop eating so you don't overeat. There's a plant slant in the communities that drink alcohol, which were all of them but the Loma Linda community. They do wine in small amounts, or alcohol in small amounts, but it's part of a group, not sitting in your room and drinking at night. They belong to the right tribe. meaning they have a sense. Most of these communities have a religion they believe in or something that spiritual. They put loved ones first, and then they surround themselves by people who do the same things. And so I will end by saying there's a bill in Congress right now called the ARC Act, and that is the Amputation Reduction and Compassion Act. And it would provide PAD screening to all Medicare and Medicaid patients, which is really important because that's not always available currently. And it will reduce avoidable PAD-reduced amputation by improving access to screening in individuals. If we look, there's about 200,000 patients who suffer avoidable amputations every year. And as you guys know, Dr. Lasar and his team has really changed the dynamic or the footprint in this area for that. And we know that PAD disproportionately affects people of color. And so the ARC Act, which is a House Resolution 4261, is something if you do any sort of advocacy, you should reach out to your congressman to talk about. So key takeaway, social determinants of health affect all of us, not just the people that are primarily affected. Improving lifestyle is essential to optimal health. Exercise and diet should be assessed and addressed at every visit for every patient. And then improving overall health requires approaches that target medical education, so conferences like this, effective interventions, and policy changes that improve access to care. Thank you guys so much. If anybody has any questions, you can email me or send me a message on X. Thanks.
Dr. Lasar was supposed to wear his workout clothes today to do some demonstrations, but we'll maybe do that next time. That was a lot of great data from Alison, so I'm going to piggyback on a lot of that. I'm also not going to spend a lot of time trying to convince you guys how important building and maintaining skeletal muscle is, but we are in an absolute crisis with sarcopenia. Not just maintaining muscle, but absolutely losing it. We all think, you start worrying about that when we're 50 or 60. A lot of the data indicates that it's probably more like 40, even earlier in some cultures. So we're losing muscle at a very rapid rate. A lot of that is the statistics that she showed that are lifestyle and environmental. So I'm not going to spend a lot of time on that. But what we do know is the amount of skeletal muscle, along with VO2 max, is now widely accepted as the two biggest predictors for longevity, as well as disease prevention and disease management. I think we, know the evidence supporting how insulin resistance, diabetes, and those pathways are impacting not only PAD, but a lot of other health things. That's a very root cause. I would propose one of our number one levers that we can pull to improve that is more muscle mass. It's the biggest glucose disposal thing that we have on our body, not only having that muscle, but also using that muscle. VO2 max is right there too, but I would interject as well. If you don't have any muscle or you're very sarcopenic, you're gonna have a really difficult time maintaining a healthy VO2 max. So to me, the foundation, it begins and ends with muscle mass. If you guys want to follow up on that, I do have a couple of books and authors. Dr. Gabrielle Lyon has a book called Forever Strong, and she's a physician that practices what she calls muscle-based medicine. And the whole concept around that is we're all aware of the obesity epidemic that we're in and all of the downstream effects on that. We've known about that for 30 years or more now, and it's only getting worse. So I agree with her perspective that maybe we're missing one of the fundamental causes of that is we are in an obesity epidemic, but one of the things we may not be aware of is the loss of muscle epidemic. And the contributing factors to BMR, insulin sensitivity, and all of these other things are very related. So her book is called Forever Strong, Dr. Gabrielle Lyon. And another one is by Dr. Peter Attia, and that's the book Outlive. That's gotten a lot of press lately. But both of those are fantastic at presenting the data and some of the stuff on how important skeletal muscle is, and it may be the most important. What I'm going to talk about today is how do we do that? She touched on some of the exercise rates. Only 50% of Americans are even doing structured exercise. 24% are doing the absolute minimum. Less than 10% are actually maintaining and actually building any muscle. So why is that? I think they're absolutely overwhelmed and confused. I think the fitness industry that I'm from has done a complete injustice on that front. And I think in general, as all providers, we can do a better job of maybe instead of just saying, hey, you need to exercise, maybe we can give them a little bit more direction on exactly what to do. I'm a professional bodybuilder. I don't like going into gyms. It's intimidating for me. It's a lot of people. I totally understand how people would feel about that. But there's a lot of things you don't have to go to the gym for, and you can do, and you can apply these principles. So I'm going to provide you today, hopefully, with enough evidence-based muscle building guidelines, and a lot of this comes from the work of Dr. Brad Schoenfeld, who's probably the lead researcher in muscle hypertrophy, Dr. Andy Galpin at Cal State University, and Dr. Brett Contreras, who's authored a lot of books on the topic, and they've also published a lot of studies. So, where do we start? You got to live in the gym, right? Not necessarily. What we do know is we need about 10 to 20 sets per muscle group to build muscle. Probably a lot less than that to actually maintain it. So, and it may be as little as 5 sets a week. These are numbers based on per week. So you could go in on a Monday, maybe do 5 sets of a compound exercise, say a chair squat. A lot of the patients that we may be talking about and dealing with, they maybe can't do a chair squat, so maybe they can do a half of a chair squat or a low step up or a step down. There's a scalability to this. But they can do 5 sets on a Monday and then come back and do another 5 sets on perhaps Thursday or Friday. And they've met that minimum requirement to stimulate muscle hypertrophy. Somewhere between 2 and 4 workouts a week is accepted as the minimum to the maybe maximum recoverable amount. You get into the 5 days a week, 6 days a week, even on the elite athletic level, it starts to compromise your ability to recover and then obviously compromise your ability to make the adaptation to achieve that muscle hypertrophy. How many reps? That's the age-old question, right? You do heavy, low reps to, gain muscle, and you do a bunch of high reps to burn fat, right? That's what we've always been told, and that's not necessarily true. The good news is, from a muscle hypertrophy standpoint, it all works. You can do, heavier, challenging reps like a power lifter or a strength athlete would do in the neighborhood of 5 or 6. Obviously, that would be stimulating for muscle hypertrophy. But the good news is, for a lot of us as we're getting older and a lot of the patient base, is you can build every bit as much muscle with 20 reps, 30 reps, and data even shows up to 50 reps. So it's a little, challenging to what we've traditionally believed. Now, the key on this, I think, is finding the appropriate loading parameters to get all the benefit and the least amount of detriment. With the really heavy weights, I think we can understand how the load may be compromising to some joint integrity, and there's most of the people that we would be working with would not be eligible to maybe lift that heavy of a weight. When you get really high in the reps, there's a quite high benefit to fatigue ratio. So if I say, well, you've got to do 50 reps of chair squats to get the benefit, you're also going to accumulate a tremendous amount of fatigue with doing that, and that could also be a little demotivating for a lot of people. The sweet spot really looks to be 8 to 12 reps, maybe 15, somewhere in that neighborhood where you can get all the benefit of lifting the heavy weight, like the 5 reps, and maybe not be as exhausted or accumulate the fatigue as it would take to do the 20, 30, 40, 50 reps. And that would also be enough load to account for a couple other things like building tendon strength and Also considering stimulus for maintaining bone density, which you may not get with the really, really light loads that you could do, 40, 50 reps with. So the sweet spot looks to be 8, 12, 15 for the repetitions. The most important part would be, how do you do these repetitions? And this is where I would interject. If somebody does 10 repetitions and they could have done 20 or 25, they're just simply moving and maybe doing a very remedial amount of exercise. I would not call that training. I use that terminology very strictly with our clients. You need to mentally accept that you are training, which implies you're looking for a very desired outcome from your effort invested. You're not just going in and checking a box. I did my 15 minutes, I did my 10 reps. No, you're training to get that desired outcome, to create that stimulus, to at least maintain muscle, if not stimulate to gain more muscle. So how do you do that? Well, it's like I said, it's not just checking boxes. That would be great, that would be easy, but it is going to take a little bit of effort. So let's talk about how those reps might be performed and different phases of the motion. Very simply, when you lift a weight, that would be the concentric. That might be the least important part of the muscle building process. It's the eccentric, which is generally on the way down, and then applying tension when the muscle would be in a lengthened position is also shown to be perhaps the second most important trigger while you're doing your resistance training. One easy way that I advocate is syncing that with a proper breathing technique. So we could do a whole nother segment on how important breathing is, but one thing I would recommend is really filling the lungs up on the eccentric, which is where the muscle's lengthening. Slight pause when it's in that fully lengthened position, and then blow out when you lift the weight. And that can be applied to almost every exercise, whether it's a squat, whether it's a curl, a calf raise. But that's an easy way to kind of standardize your repetitions. And that's another thing I encourage people is, you'll often go to the gym and you see people, then they do a set of 15. The first 7 or 8 look fantastic. The tempo is really nice. And then the brain kicks in and says, this is starting to burn a little bit. And then things start to change, and the breathing changes, and they start hyperventilating, and the tempo changes. And I often challenge people and say, well, what are you counting at that point? The point of counting is to collect a group of repetitions that are very similar and very consistent. So as that changes, the effectiveness more than likely drops off. So I do think it's very important to create a consistent standardization when people are performing their repetitions. There was a slide a couple back ago you might have seen, reps in reserve, if you guys keep up with any of the YouTube jargon and the stuff. And you hear a lot of people about training to failure, which I would define as you can no longer perform a repetition in great technique. So the data on that is pretty clear. You don't have to train to failure, meaning to complete muscle exhaustion. You get within 2, 3, 4 reps of that, it's probably going to be good enough, and training to failure doesn't add tremendously more value. But coming close. Real world, what does that look like? I often tell people that first rep that really slows down. So back to the tempo thing, when you're really doing your breathing and you're doing your tempo and inhaling on the way down, exhaling on the way up. First rep you get to that's a little bit of a slow down and a little bit of a strain, that's what I would call an effective rep. So back to the minimum 10 sets, over that 10 sets, if I get 1 effective rep every set, I've got 10 effective reps for that workout or over that week. And that's what's going to be very effective for stimulating the retention and building muscle hypertrophy. So effective reps absolutely matter. What type of exercises generally have compound, which include multiple joints, multiple muscle groups? And then you have what most people call isolation exercises, or I would more of a single joint exercise. Both have high value. Both can result in similar degrees of muscle hypertrophy. The big benefit in doing compound exercises is the time and effort efficiency. So if you do something like a squat, you're involving your quadriceps, your glutes, your hamstrings, your lower back. You've got a lot of muscle groups. So now in one exercise, I can do my 5 sets for my workout today and have knocked out a large group of muscles. If I stuck on more isolation machines, I would probably need to do my 5 sets of extensions, 5 sets of leg curls. Glute bridges are popular, calf raises. So now I've got 2 or 3 times longer in the gym. But with that said, I think those isolation or single joint exercises could be very beneficial for most, because I think the patient base that we may be talking about may not even be eligible to do a chair squat, and oftentimes, or the great data that Alison presented on walking. I've had clients that they have certain muscles that they've not used in so long, they just don't work very well, and even going on a walking program, that actually increases a risk of injury because they're not even eligible to do that. So using isolation exercises to kind of tune up and bring up certain muscle groups, they certainly have a high value, and so along with that comes the benefit of the muscle hypertrophy. Rest between sets. This is another confusing thing that my industry has done a very confusing job of. I think the one thing we have to continually come back to is, what is the desired outcome of this exercise session? And there's a long list of benefits of what that could be, but from a muscle hypertrophy standpoint, we're going to maintain at the minimum, hopefully build more muscle. You need to take adequate rest so the next set is effective. You can get that effective rep, and your limiting factor is in fact that target muscle. So if I'm doing a bicep curl, or better, a squat may be a better example, and I do a tough 15 reps, the last rep is pretty challenging, and I take 30 seconds rest, it's very likely lack of aerobic capacity or other things may be the limiting factor that prevent me from getting a really good second set. 1 to 3 minutes is ideal, so that's a good range, but I would encourage a good rule of thumb is just take long enough, take deep breaths, and go again when you're ready to do another effective set. Supersets can work great in that, so antagonistic or opposing body parts you can pair well. That definitely helps on time efficiency. So hopefully that clears up some of the things. Honorable mention, which is more along the lines of make or break. If sleep's not in line, all of this may be for naught. If you don't meet the minimum protein requirements and energy, it may all be for naught. And it's worth mentioning other modalities that could improve recovery, walking, aerobic training, stretching, soft tissue maintenance, all of these things to help the process along. But that's, in a nutshell, hopefully that was helpful with kind of structuring a workout. And I know the fitness industry presents very confusing because we've kind of been guilty of, we're going to try to do a whole lot of stuff at one time. We're going to improve aerobic capacity, strength, stretching, mobility, and we're going to do it all at once. And generally the result of that is you're not great at any one thing, even though that's general. So hopefully that helps clear up if the goal is maintaining and even building muscle. All right, thank you.
Greetings, everybody. Good morning. I am Ed Jones, owner of Nutrition World, and I'm welcome everybody. Dr. Bailey, thank you for your great points. Matt, wonderful. And I hope to share some good wisdom with you today. Nutrition World's been around since 1979. I opened it myself, and I've had a passion my entire 66 years of living to learn about what helps me to live longer, and then how can I empower others to do that in the same form and fashion. Made a lot of mistakes along the way, but that's most of the time how we learn our lessons in life, is by mistakes. But it's time now, in my opinion, for embracing the future of what I call personalized health care. And this is certainly a concept that's been around for many decades, but the rubber hasn't met the road in regard to that often. It is a very nice word, but it doesn't really work in the medical model that has been what we have lived with for most of our life. You know, there are 4 books that were voted on by medical professionals as most of the most impactful books of their career. One is the Merck Manual. Certainly understand that for especially students and people who are learning, or in reference. The Atlas of Human Anatomy. That is obviously very important for the people in the right place. Being Mortal, I've not read it, but it was one of the voted books. And The Emperors of All Maladies. And my prediction is, with all these amazing books, I still think there is one missing, and that is something that I believe will be book number 5 when we look back in history. That is the one Matt mentioned, Outlived by Dr. Peter Attia. I rarely have found a comprehensive plan for health that has equaled Dr. Attia's view on what we can do to personalize medicine. He talks a lot about this word lifespan, which we all know, versus health span. You know, many people live to be 80, and they stop breathing at 80, but they actually died about 50 because their quality of life diminished to a point that they really never felt well enough to enjoy the gifts of our kids, our grandkids, our jobs, our hobbies. And if you look at the graph, you can certainly see, with no intervention, you're probably going to live a life that's based on managing lifespan. It's not what I'm interested in. I've lived a great 66 years, and it has been vastly full of quality of health span, not lifespan. If tomorrow was my last day, I have been very, very blessed and graced with the fact that whatever I have done has helped me to enjoy what I am doing 100%. You know, longevity does not always result in positive outcomes. Certainly people who, and you professionals, have seen that with the senior citizens who are barely treading water with their daily lives and wondering what's next. Well, this is what happened to the mythical god named Tithonus, who asked the gods for eternal life. To his joy, the gods granted that wish. But because he forgot to ask for eternal youth as well, his body continued to decay. We're kind of in that in many, many areas of this country. The 4 greatest health issues by Dr. Peter Attia that are facing the patients of this country are heart disease, neurodegenerative cancer, and type 2 diabetes. And I think the most important word is metabolic function, which is part of the type 2 diabetes. Metabolically inflexible people are those who have, to make it very simple, in my world, we see 300 to 400 people a day at Nutrition World. And a lot of people do blood work. A lot of people are really embracing their own path with helping with the teams that they feel confident, the physicians, the counselors, the trainers, Matt, the people who can help health coach them to better health. And anyone who has an insulin level of over 10 to me has work to be done, bar none. I don't care. You can say what you want. If it's over 10, you probably will have a hard time losing weight, and you're going to be metabolically inflexible. The key is, what do we do to lower it down to 5 and under? Peter Attia, the largest failing is in attempting to treat the 4 horsemen, which is those 4 disorders, at the wrong end of the time scale, after disease is entrenched rather than before they take root. I think we all can connect with that. However, the medical model that with insurance and things, you really can't help it. So it's not like there's blame to be had, but there has to be a better option. And as a result, we ignore the important warning signs and miss opportunities to intervene at a point where we still have the chance to beat back the disease, improve the health, and increase not only lifespan, but health span. He calls it Medicine 3.0. I love the way that he categorizes this in very simple terms. And he talks about something called a centennial decathlon. I really connected with this. He starts talking about patients' histories, which I'm very, very familiar with blood work and everything from the GFRs down to the liver functions. He says, do you really think that a person who's 65 years old with a GFR of 50 has a chance to get to the 80, 90, and 100-year-old? No, they don't. They don't. So what can we do about that? Well, maybe we can manage the GFR in a way that can improve it through lifestyle, through exercise, through nutritional supplementation, through the right pharmaceuticals if it's adequate. But, Dr. Lassar said something in his introduction that I actually wrote down here because it's so applicable. When he told his students that he was training in surgery, you are in charge of your own education. That came out of his mouth. That was very impactful to me. Every one of us and every one of our patients who are still capable of thinking on their own are pretty much in charge of their own education to help themselves to live this centennial decathlon. But that takes a plan. It takes a plan of action. It's not hope. Hope will not do us any good. It takes a plan. So how do we create a plan? First off, you create team members in your life. I always have 3 team members every single day I get to my Nutrition World office. They're the 3 people, and they rotate constantly, that are teaching me more about health and nutrition and lifestyle. We have the most amazing tool called a cell phone. It is our remote control for your future. Yes, it has some really negative things to it, but you don't have to choose those. You choose the teachers on your cell phone through YouTubes, through podcasting, through whatever means you have, and every single day you learn from them. Every single day. I'm bringing up 3 to 4, and I'll change as the months go on. But that's how we learn. We don't learn by reading and studying the same things we always have. And we do know, Dr. Bailey talked about it, Matt talked about it, the most powerful drug ever invented that no one can contradict is exercise. Nutrition World brought, and there's on the right, I'll have to say old timers, if you recognize the guy on the right with a German Shepherd, Jack LaLanne. He was the ultimate guru of fitness in the 1950s. Memorial Hospital and Nutrition World partnered many years ago and brought him to Chattanooga. And I introduced him at Hamilton Place Mall, and he lived to about 95, 96. Just amazing individual. Just a few other things. Matt talked about this, how VO2 max declines with age. VO2 max is probably the #1 correlation with longevity, strong health span, not just lifespan. But here's kind of the frustrating thing about it. As you see on the chart, the older we get, even the elite athletes are going to slip down on VO2 max. I say this constantly, Father Time is pretty damn cruel. But we can counter it really well if we empower ourselves with the education we need. But even with that, you can see that we're going to have to work harder as we age. We don't get to be couch potatoes. We actually have to do more at 66 than I did at 46 and at 26. The other thing, the association between hand grip strength and dementia incidence. Basically, someone with a 40-kilogram grip strength has 40% as much risk of dementia as someone with a 10-kilogram. Well, the thing is, it's not really about hand strength, but that's a correlation to the overall system and body that's working. And mortality risk for non-elite fitness and select comorbidities. We have to exercise. If we do nothing else, we do have to do that. But there's so much more we can add on top of that. And again, one of your team members needs to be a personal trainer, perhaps. It's going to be hard on your own if you don't have that. And my tip of the day that I've said for 30 years to my clients about exercise, this is how I've always done it. Now, I'm a little obsessive, I will say. I'm certainly admit it. Those who know me know that. If I wake up tomorrow morning, I will say to myself, did I exercise yesterday? If that answer is no, nothing will get in my way. It has to be done. Okay, if I can't get to the gym, something's going to get done. I'll have kettlebells in my house. I'll have a treadmill. I'll have something. So if you wake up, did I exercise yesterday? Yes, I did. Well, you have an option today. Well, maybe I'll do it again. Maybe I won't. But if it was no, then you have to do it. My commitment to this health, to the health of this city is quite serious. And so I'd like to offer a gift to all the local practitioners. I'm going to purchase this book for all of you on Audible. Anybody who wants this book, Outlive which is the plan from A to not A to P, but A to Z on what we can do as practitioners with the blood work, the management, the striving for optimal, not average in the lifestyle management of everyone. So if you want this book free, all you got to do is send me an email at nutritionworld@comcast.net with just your name, your scope of practice, and your address, and of course the email address, and I will hook you up with this book. I loved listening to it. I love to read too, but his sense of passion comes through in this book about all his mistakes he made with not only his patients, but his own life. So please take advantage of this if you would like. And I do feel very confident of this statement. When people know more, people generally do better. That means that we can't just send somebody home and say, I want you to exercise. We didn't help them to know better. We kind of scolded them. I want you to eat better. That didn't really do a whole lot. So we need to help them educate themselves, like Dr. Lasar said. Services that Nutrition World offers to become a partner with your patients, clients, friends, and family. Again, putting that team approach. Nutrition World has 17 practitioners. We've got a pediatrician now, Dr. Litwin. We have Dr. Brian Johnson, 25-year history in hospital client and patient management. We have the Holistic Podcast, Navigator Podcast, educates on 104 different issues of health. The YouTube channel is full of our information. We've had, I did 2 posts within the past 6 months. They hit about $1.2 million. Yeah, they hit me to 1.2 million, no, but 1.2 million views. It was on me walking through Food Lion and picking up a container of margarine and talking about how unhealthy this product is. It's nothing but plastic. That's why it sits on a shelf for 20 years and it will not degrade. We can't build our cells from plastic. Second was on Campbell's soup, using more of the genetically modified ingredients. Both of those hit over 1 million views. People are interested. Our nutritionw.com blog podcast got 8 million views on TikTok. People are hungry to learn. Our services are part of their team. And I want you to know that we can be helpful to your clients, your patients, your friends, perhaps as part of their team and part of their education. And I want to thank Dr. Lasar and Tracy Lasar for having the guts and courage to bring people up that are kind of outside the box, because I know the world is changing and I am so thrilled to see it. I didn't know if I was going to live long enough to see the change, because I lived in the 80s and 90s and a little bit longer than that with being very, very attacked in the opinions and the business that I'm in. And it's now we're friends of so many people in the medical field, and it just thrills me to death. So thank you all, and we're here to help if you ever need us.
Hello, everyone. So good to be among all of you discussing how we can improve patient care and what we can do to potentially really do something significant in the near future for what we do with our practices and for our clients. So my discussion today is over emotions and their effect on the body. I don't believe that that's discussed enough among healthcare professionals in Western medical technology, so I thought I would cover that just a little bit. My titles are somewhat vague to most of the people here. Functional health coach, trauma-informed life coach. All that simply means is that I've been educated in somatic and gestalt therapy and a few other things that allow me to have a little bit of a different perspective than what we normally have in Western medicine. So on the agenda we have emotions and their role. I don't believe that's discussed enough. Total body wellness, and how emotions play a very important tie into that. Stress and the heart, which many of you are already educated on. We're going to discuss that just a little bit more today. And final thoughts from me. So emotional well-being has been inextricably linked to biological health in many ways. Today we know some, certainly not all of the specifics of how emotions affect the body. What are emotions and how do they affect us so? So this is an important quote from Gabor Mate that we'll revisit here in a moment. Gabor Mate, if you don't know, is a noted psychologist, very well educated and has a lot of accolades behind him. He says, grieving is trauma leaving the body. So notice how he includes the body there. What does he mean by that? Exactly what are we tying into grieving there? So you can see this is one of the charts from Dr. Peter Levine's seminal work. It's in a book called Waking the Tiger. Might want to pick that up just to have a little bit more of an education on how emotions affect the body, because what he is the father of somatic therapy. Somatic therapy is the study of how emotions interact with the body on a cellular level and on a biological level, but more importantly on how they interact with us on a pragmatic level, how it plays out in our daily lives. And so you can see there, this chart, what it notes is, see the green line there? That green line that meets the threshold, right, of an energy release from the body that is complete and then dips back down after the nervous system dysregulates and then comes back up. That is what happens after trauma in animals. So what Dr. Peter Levine thought was, hey, I don't believe that trauma is permanent. I don't believe it's something that has to dictate the lives and the health of my patients. I believe it's something that we can actually move through a little bit more to the point of getting rid of it on a permanent basis. And so he wanted to discover what that was. He said, hey, well, what do mammals do in the wild? Because we're mammalian, and so we have similar nervous systems. They respond to almost the same to antidepressants and to anti-anxiety medication as we do. What do they do with trauma? And how come I don't see any depressed lions or manic cheetahs in the wild? And so he wanted to figure that out. And so what he discovered was when animals have a visceral trauma, say for instance that they almost get eaten alive or part of their litter is lost or something like that, then they immediately have a release from the body, whether that be a shaking, whether that be a galloping, a movement forward, or whether that be a rolling around in the dirt, howling at the moon, whatever it may look like, but they have a very visceral release from the body until the trauma is actually dealt with and released fully. And then once they do that, they dysregulate. And as they dysregulate, they come back out and they come out on the other side as if the trauma never happened. Right? So they have the absolute freedom to do that. He knows that they have a very honest relationship with their body. They don't have any drugs that they cover up their emotions with. They don't eat a lot of caffeine and sugar. They don't have any hard drugs that they turn to. Nothing like that. They have a very open and honest relationship with the cycle of their emotions. Right? So it gives them a distinct advantage over us. A, is their environment offers them no way to escape their emotional cycle. Right? Number two is they're automatically accepted by their pack. They don't have to worry about if they have deep release, that they're going to be rejected by their tribe. See, for thousands of years, what we have done as human beings is we lived in a tribal state. We had to because you had roaming packs of predators that would take you out if you were single or alone, right? So we learned that we had to group together in order to survive. We learned that that's what we had to do in order to really make it in the world, because you even had roaming packs of people that would do the same to you if you were alone. So raising a child, getting in food, just very basic living items for thousands of years, we learned that we had to be together. And so rejection from the tribe meant death. Acceptance meant life, right? And so in that, what we did was we had it hardwired into our lineage, into our DNA, that we have to have acceptance into the tribe that we're born into. And so when parents come along and say, hey, that's enough of that crying today, I really can't handle anymore, or hush up that crying, we'll give you something to cry about, or in some homes when it gets a little bit abusive, you even get smacked for crying and those kind of things, right? What that teaches the child at that point is that there's only so far you can go with emotions here. We don't handle deep emotional release here. That isn't something that we do. And so you can cry about something maybe if you absolutely have to, or to manipulate, wink, wink, and we'll figure out a way around that. But other than that, the deep grieving that you may need to do as a child, right, is not accepted. So that very deep, say for instance, fetal position, snot bubble kind of rolling around the ground crying is not accepted in our tribe. You can only go so far with that. And so what that does is, when we turn it inward, you can see there on the chart what happens. Instead of like wild animals where they're able to release until they're done and then get it out and move on, right, so they can survive, we actually stuff it. So we represent the blue line there, and when we dysregulate, we go into depression. Or if we have a cyclical thought around it, then we go into anxiety, right? And if it's a deep enough trauma, then we go into the dorsal vagal phase, which is basically a deer caught in headlights playing dead, that kind of thing, where the shock is so intense that our body just kind of freezes up. So I wanted to cover that because I wanted to make a note that the emotional aspect of what we are cannot be discarded. It's not something that you can just get over. It's not something that we can just bypass. It's something that we all need to know as healthcare professionals that our patients are walking in with, because to Dr. Bailey's great presentation, right, most of the people that are coming into our offices are people that have states of disease, people that have states in their body and in their lives where they have built up a certain lifestyle and gotten their bodies to a certain state where it started to develop some things that are not that great for them. And in that, what they've also encountered most of the time is great emotional distress. Rarely have I had a client come into my office, right? I see around 120 people a month, which may not sound like much to most of you, but each one of those patients I'm spending an hour with. So that is quite a bit of work there. And so in that, out of all the patients that I've seen, and I've been doing it for a while, not a single one has come in and said, you know what, this disease started just out of nowhere. It seemed like it was just out of nowhere, and then it just happened. Every single time I said, well, what was happening in your life when this disease started? Well, my dad died. Or, my brother passed, or I was immensely stressed in my job, and I just lost it, and I had my survival threatened, those kind of things. In other words, they were encountering trauma at the time the disease started. That's extremely significant when you think about that from a perspective as a healthcare practitioner. Why aren't we having more conversations about ways to integrate better care for our patients when it comes to emotional distress in a practice that sees people that are diseased? It's very interesting, right? How can we integrate that even more? It's more than just sending them off to a counselor. In the moment of disease, when you encounter them as a doctor or as a healthcare practitioner, right? When they are encountering you, a lot of times they are in great distress, great emotional distress. We need to understand that there is a way to approach emotions. There is a way to approach what the client's going through that actually supports their biological health. It intersects. So let's look at that. How emotions operate in our lives. You can see that bottling up the emotional process can greatly increase these things in patients' bodies, increase inflammation and joint pain, headaches and allergic reactions, digestive issues, and lowering of immunity, cardiovascular problems, heart attack, and then heart disease. The quality of life starts to decline, so bottled up emotions are the main cause for depression and anxiety. Negative emotional states greatly contribute to unhealthy habitual living, lack of motivation, and overall body wellness. So take that in for a moment. We're all healthcare practitioners here. How come this isn't focused on more? What's going on? If we know for sure that the data shows all this and indicates this, why aren't we integrating something into our practice, like, say, for instance, a board-certified health coach that knows how to validate your patients on the way out after they have a really hard diagnosis, right? Because as a doctor, I'm not trying to put more on your plate. I'm trying to say, hey, let's resource our patients with a better plan, because you're busy enough. Doctors have enough on their plate. I understand that. But what about really thinking and getting together and saying, how can we really include this in a part of the healthcare, because it's such a humongous deal? Let's go into it a little bit more. Emotions influence the body. Let's go a little bit deeper. So digestive. Emotions affect the acid production in the stomach in various ways in which we break down nutrition. Let that sink in. If you can't break down nutrition properly, right, then what happens when it comes to cardiovascular health? What happens to all aspects of health? Emotions can change quorum sensing for better or worse. Quorum sensing in the gut is where the microbiota communicate with each other. If the microbiota cannot communicate with each other, exactly what is happening in the gut that supports health? Short-chain fatty acid production is not happening the way that it needs to. That's ultra important for cardiovascular health, right? And gut permeability is something that's really affected by it. All of this has a cascading effect on overall heart health and well-being. And then we go into cellular health. This is really, really important here. Most doctors that I've trained under would say that cellular health is the future of medicine, right? And so let's look at emotions can change the way in which cells signal, affecting autoimmune, detoxification routines, and overall well-being on a foundational level. That's huge. Emotions are the beliefs we carry that support them. Emotions and the beliefs that we carry that support them directly affects our DNA and potentially speeding up cellular aging. That's amazingly huge as well. Where are the discussions in Western medicine about how to integrate this into practices? How do we educate and inform our doctors and our healthcare practitioners that this has to be covered with patients once they get a diagnosis in your practice and they're at a loss, or they come in at a loss already, right? Just something to think about. So emotions, let's talk about cardiovascular health. Many of you already know this, but let's cover it anyway. Emotions affect the way the heart beats, the vasoconstriction and vasodilation of the blood vessels and capillaries. Emotions are responsible for stress, cardiomyopathy, or literally broken heart syndrome. You all are very familiar with that, I'm sure. Emotions can change the way blood clots, how the liver processes fat for cholesterol, and how the arteries harden as we age. People who are chronically stressed, anxious, depressed, or angry may be more likely to drink too much alcohol, smoke, overeat, and get less exercise. All unhealthy habits that are bad for your heart. You remember the charts that Dr. Bailey so astutely put up here around the areas in which we have more cardiovascular disease and about poverty and about different things like that. In those maps, you can also see that they're more anxious and depressed. If you were to pull that up, a map or a chart overlay, right? The more poverty-stricken a place is, the more you're going to have anxious, depressed, trauma-filled people. Right? So let that sink in. If they're higher in disease in those areas and they're more anxious, depressed, and stressed, there's a direct correlation there for sure. Even in people with no prior heart disease, major depression doubles the risk of dying from heart-related causes. So out of all the things, right, that we have mentioned today around exercise, around nutrition, around everything, I don't know if I've seen one thing that doubles the risk. Doubles the risk for heart disease. That's major depression. So these are big things that you need to tackle in your practice if you're a healthcare professional, or at least have a plan around. And it's more than just prescribing a pill for it, correct? Because if you prescribe a pill for it, right, all that does is disconnect the patient from how they feel a particular way and maybe short some brain chemistry. But what they need is better habits. They need a way of handling the trauma that has happened in their lives with a plan that's well educated and informed around their emotions and how they operate and work. They need to know that their emotions just can't be shuffled aside, that they're hardwired in our DNA and they're hardwired in our cellular and nervous system health for the long term. And so it's very important that we understand that if we do give them a pill for stress or depression, that we also say, hey, you don't want to be on this for the rest of your life, like 20 years from now. You actually want to develop a plan around supporting yourself well enough and having a team, like Ed said, that validates you, that supports you, that gives you the overall plan for emotional well-being that you can have and that you need desperately for your biological health to thrive. So in summary, emotions are hardwired, integrated into our biological existence. You're not going to separate them from cellular health or cardiovascular health. It's just not going to happen. So we need to be more educated on what we can actually do around that and have a plan. Emotions irrefutably play a pivotal role in our biology and overall well-being. We must find a way to integrate more direct and informed emotional care for patients to truly heal disease and be supported through what they are going through as healthcare professionals. It is a mandate. It's not something we can just bypass. Thank you so much.
Speakers talked about VO2 max, and that's your functional capacity. If you've got an Apple Watch, it records it. It's your cardiorespiratory fitness, and it gives you that number on there. So it's kind of cool to look at, and it tells you where you are as compared to where you should be for your age and gender. So I would encourage all of you to do that. I pull my patients' phones out when they come to clinic and look at their cardiorespiratory fitness just to see how well they're doing. And I do CPX testing, which is VO2 max testing, and I compare it, and it's pretty accurate for people who get on a treadmill or a bike in the lab and use their watch data. So I'm sure other ones do it, but Apple's the one I'm familiar with.
Yes, ma'am.
So I have a question for Matt. I wanted to know the difference between aerobic versus anaerobic.
Technically, so that'd be with or without oxygen as your driving fuel source. So the anaerobic is usually going to be the very short. I made a note on the slideshow if you saw HIIT versus LIS from a cardio. HIIT stands for high intensity interval training, to piggyback on the VO2 max. In the exercise world, oftentimes if you go to the gym and you tell the trainer or the person on staff you want to work on VO2 max, that's probably the first lever they're going to pull. And the definition of HIIT would be doing a very, very hard, all-out, 30 seconds, interval followed by a rest interval of maybe twice the duration. The data on VO2 max, the good news is that, I think she touched on that, walking it can absolutely be amazing. So the HIIT can, you know, the people that want to do it or the people that maybe need to do it for a sport or want to challenge themselves a little bit more, it's awesome. But walking, you can get really, really good results also just from walking. But yeah, and of course, all weight training generally is going to be in that anaerobic threshold. And from a muscle building standpoint, I would encourage to kind of keep it there. That's also where it kind of gets blurry is a lot of strength training coaches tend to push you to the point where you're aerobically spent, and that's usually a limiting factor for your ability to build muscle.